Thank you, Dr. Yuza, for inviting me to do this. So this is a little less cool than everything else that's been talked about, so I'm just going to give that as a disclaimer. So I'm going to be talking about nasoenteric tubes. These are my disclosures, but none of them are relevant to this talk. So just in terms of why enteral feeding, I think a lot of us kind of know this already. We definitely want to try enteral nutrition as much as possible compared to TPN, and definitely in our hospitalized patients. The reason is it preserves the gut barrier function. It's less cost intensive compared to TPN, and it has improved patient outcomes. And for us as surgeons, it improves wound healing as well. So these are just the various nasoenteric tubes that are on the market. Probably the first one is the one that all of us are very comfortable with in terms of using them for suction. So that's the Salem sump tube, so it's mostly for suction, but you can also use them for feeding. The bottom four are mostly for feeding. The bottom two, the Dobhoffs, have weighted tips at the end, so it helps with placement. They also, the bottom three on the right, have wire stylets that help to stiffen the tube so that it's easier to make sure that the placement is adequate. The one on the far left is a Levin tube, which has a single port. So in terms of why we want to use these tubes over the other tubes that's already been discussed, this is definitely for a short-term enteral access. So this is very useful in our patients that we know that are hospitalized. They're not going to need any enteral feeding afterwards. You know that they're going to have a good oral intake after they're discharged. So this is mostly as a temporary solution for feeding, but they should only stay for about 4 to 6 weeks maximum, after which you probably should consider all the other methods that have been discussed already. This is the least invasive in the sense that there's no actually incisions anywhere. It's put mostly through the nose, and there's mostly different methods of putting them in. You can put them at the bedside, you don't even need to go anywhere, and then we can use adjuncts such as endoscopy, fluoroscopy, and electromagnetic assistance, and these are very similar to the techniques that we've already been described. So in terms of disadvantages, I'm sure everyone knows it's not very comfortable to have a nasoenteric tube in. So it's not a long-term solution, and it's not very comfortable. It irritates the back of the throat, and there's a foreign body sensation, so it's very poorly tolerated. Because you're stenting the GE junction open, you can cause some reflux esophagitis, cause some sinusitis in the nose, and pressure ulcers, so it's not the most comfortable. As everyone also knows, patients have a tendency to pull these out and have them dislodge. So it's not the best sort of long-term solution. Despite all the bridles and all the tape that you use, they can still get dislodged. But again, it can also significantly interfere with swallowing training. So having something in the back of the throat, if you want to do a swallow study on them afterwards, it's quite hard. So in terms of different ways, I think we've kind of touched on it a little bit, but we'll touch on it again. So in terms of if you want to put this at the bedside, that you can just put a nasogastric tube in. It's very easy to put in. The nurses can put it in at the bedside without any sedation whatsoever. However, putting food in the stomach, if the food just sits there, there's an increased risk of aspiration. They can get pneumonias, and they can have food regurgitation. So that's just something to consider. So it can be contraindicated, particularly with patients with gastric outlet obstruction or gastroparesis. So that's why we consider post-pyloric tube feeding, so I'm mostly going to focus on that. This is obviously a little harder to put in, so they do need other adjuncts sometimes. You cannot necessarily put them just at the bedside. In terms of spontaneous migration, it's about 5 to 15%. You can use things like metoclopramide or erythromycin to help with promoting tube migration to after the pylorus, but it's not a guarantee. So it's good to use fluoroscopy or endoscopy in these as adjuncts, as we've touched on already. So in terms of nasojejunal tube insertions, these are just different ways that we can put it in at the bedside. That's probably the most common, but again, it's not a guarantee that it'll actually reach the jejunum or post-pyloric, so it's not the most successful way of doing it. And you can see here that the success rate is much improved with endoscopy, fluoroscopy, or external magnetic guidance. Fluoroscopy is mostly an external magnetic guidance. Both of the bottom two do not require any sedation, whereas opposed to sedation is required for endoscopy. I thought this was a little interesting, but this is an external magnetic guidance. This can be done at the bedside. You don't have to move them anywhere. And it can be done by trained professionals such as nurses. It doesn't necessarily need any radiology or endoscopy suite access. Essentially what is required for this is that there's an electromagnetic transmitting stylet at the tip of the feeding tube, and there's a receiver placed on the epigastrium. Using the monitor, you can actually track the path of the tube into the stomach and post-pyloric replacement. It's about 85% successful, which is not terrible, and it's found to be pretty safe and effective compared to other modalities. So if you have a patient that's extremely sick in the ICU, this is something to consider. So I'm mostly going to focus on endoscopic guidewire techniques. There's different ways that we can put these in using endoscopy, but some of the first one that we're going to talk about requires an oronasal transfer tube, so essentially putting a tube in the nose and exiting the mouth in order for it to be converted into a nasoenteric tube. You can also do this concomitantly with fluoroscopy to make sure that your tube's in the proper place. And probably the most difficult step in all of these methods is really wire exchange or the tube exchange without removing, so once you remove the endoscope, making sure that the wire stays in place. That's probably the most challenging step, to make sure that it doesn't get dislodged while you're trying to put them in. So this is just a sort of an illustration of how this is done. So you have your oronasal transfer tube in place in the first picture, and then you use the endoscope to make sure that you go directly into the jejunum, and then you place your guide wire through the biopsy channel, and then once you sort of exchange, remove the endoscope, making sure the wire stays in place, putting the wire then through the nose in order to advance the tube over the wire into the desired location. And that's why fluoroscopy is useful in this adjunct, to make sure that the wire stays in place throughout this process. But this is the dragon pole technique. This is probably the most common, the one I probably use the most. This is essentially just putting your nasoenteric tube through the nose directly, sort of blindly, and then using your endoscope, grabbing it with the biopsy forceps and dragging it to your desired location. Things that help with this is suturing a suture onto the end of the tip, so you can use that to drag your tube through the GI tract. And then you can also use a mucosal clip to actually clip the tube in place, so that definitely helps. The double guide wire technique is essentially putting two guide wires through the nasoenteric tube just to stiffen it a little bit more. So this is adjuncts pretty much described earlier, but putting a suture at the end, and most of the tubes don't come with that, so you can actually do that yourself, and then using the clip to actually sort of clip it in place so it doesn't get dislodged. So in terms of the transnasal technique, this is actually using a transnasal scope. So it's not always available at every single institution, so there's something to be considered. But this can also be performed without sedation because the scope is going directly into the nose. This does not require any oronasal transfer tube, and you're essentially putting the nasoenteric tube through the biopsy port, or the biopsy channel. This is a little bit more difficult to navigate, and because the scope is a little bit less caliber, it's harder to actually traverse. So it's a little bit operator dependent. In terms of tube complications, probably the one that we worry about the most is probably tracheal, pulmonary, or pleural malposition causing pneumothoraces, or getting the tube clogged up, just because it is a very small caliber tube. This is usually about 8 to 12 French, so it is a lot smaller compared to the PEG tubes. So in conclusion, I just wanted to say that nasoenteric tubes are mostly a temporary short-term feeding access. You need to determine whether they're okay with nasogastric tube or nasojejunal feeding, but using other adjuncts such as endoscopy, fluoroscopy, and external magnetic guidance can be particularly helpful.